Welcome back to The Exam Room, a podcast where we dive deep into the world of value-based care, patient-centered healthcare, and improving health outcomes, with your host, Dr. Rhiannon Windsor. Dr. Windsor is a certified surgical technologist, healthcare educator, and the manager of training at VB Care Network. With almost 30 years of experience in healthcare and instructional design, she's spent her career helping clinicians and care teams optimize patient outcomes. In this episode of the Exam Room podcast, Dr. Windsor is joined again by Dr. Andy Mayberry, family physician at Chiricahua Community Health Centers in Cochise County, Arizona. Together, they dive into the world of data-driven care, exploring how annual wellness visits, care gap tracking, and strong care coordination can transform outcomes for high-risk patients. Dr. Mayberry shares his straightforward approach to prevention, the importance of continuity in primary care, and why managing data isn't just about metrics, it's about truly knowing your patients. We thoroughly enjoyed this conversation, and we're sure you will too. Let's get into it.
What other data are you looking at or is important regarding these high-risk patients?
I try to approach all the patients the same, let's say it that way. So all of the patients have a certain way that I approach them, and then if certain switches are flipped or they meet certain criteria, then we go down this path, and if those switches are not flipped, then we go down another path. But every single patient needs an annual wellness visit, Medicare annual wellness visit, and at that Medicare annual wellness visit, you assess certain things. For starters, you find out who their specialists are. And so sometimes you're like, okay, who are your specialists? And they're like, oh, I see a nephrologist, I see a cardiologist, I see a pulmonologist. You're like, what? You see a pulmonologist? I didn't know you saw a pulmonologist. Oh, yeah, I've been seeing a pulmonologist for the last couple of years. I haven't gotten any notes from your pulmonologist. Oh, that's because I was referred to the pulmonologist by my cardiologist. And I'm like, okay, so the pulmonologist is not sending me any notes. And so then I have my staff send to the pulmonologist a request of information with the patient's signature. So now I start getting those records. So that's the first thing I do is see what specialists are you seeing. And so some of my patients, my low-risk patients, aren't seeing any specialists, and my high-risk patients are seeing specialists. And so you ask, how do I approach a high-risk patient? I approach them all the same, find out who their specialists are, and then if they have a lot of specialists, then I make sure that I'm getting those records. Okay, that's step one. The next step is that we assess, just kind of do a risk assessment. How's their memory? Are they at risk of falling? Are they up to date on their immunizations? And our EHR has it's called clinical guidelines, I think it's called. Are they up to date on their mammograms? Are they up to date on their colonoscopies? If they're on a high-risk medication like an opioid, have we had them sign an informed consent on the opioid? All of those type of things. And again, if they don't have any of these things, they're not high-risk patients. If they do have these things, then they are higher-risk patients, and we address those. But I look at it as I'm treating them all the same in that I assess that aspect of their health. And then if that aspect of their health is negative, then I move on. If that aspect of their health is positive, then we deal with that issue. And those happen to be the high-risk patients. Are they up to date on their immunizations? Do we have an advance directive on file? Are they smokers? Do they drink? Or do they use opioids? And all of those things are addressed. So that's, in my opinion, that is the key to develop a treatment plan, a preventive plan for the patient based on their annual wellness visit. Then once you have their annual wellness visit in place, and it doesn't have to be, you can back into it a little bit. You can get all this stuff first and then do the annual wellness visit. But in my opinion, the annual wellness visit is kind of where everything comes together. You make sure you have the annual wellness visit and make sure that you wrap your head around that. Medicare says that the annual wellness visit can be performed by several people, including a pharmacist, that there are several people who can perform this annual wellness visit and it's still quote unquote legal or applicable. I completely, wholeheartedly disagree with that. There is one person and one person only who should do the annual wellness visit. And in my opinion, that is me. If you're my patient, I am your doctor. Yes, we have a team. It takes a team, and if I need help, but I am the center of the world when it comes to your medical thing. And everything goes through me. The buck stops here. I don't want somebody else deciding what your risk is. I don't want somebody else. That needs to be me because I own you. as a patient. Patient should just be assigned to a provider, and that provider is the one who does the annual wellness visit, so that they can wrap their head around all of those person's medical problems. They review every single medical problem, every single medication, every single whatever, and then you're like, okay, now I got it. Because a lot of times I'm seeing a patient who I've been seeing for years, and then they're seeing me every 3 months for their diabetes, and then I forget that they have this other problem. I don't know what an example would be. They have this other problem. Then at the annual wellness visit, I go through their med list, and I'm like, oh, wait, I forgot that you had XYZ problem. Somebody needs to, once a year, comb through that chart with a fine-tooth comb, covering every single medication, every single whatever, and that needs to be, in my opinion, the primary care provider. And then once you do that, you have the RAF score assigned, you make a decision of, okay, how often does this person follow up? You need to see me twice a year, you need to see me once a year. I have plenty of patients who see me once a year. The 70-year-old guy who hikes 20 miles a week and has no medical problems, he's on no medications. He still needs to see me to make sure he's up to date, make sure he's getting his flu shot, make sure that he's had his pneumonia shot, all that kind of stuff. And I say, okay, I'm going to see you in a year. As opposed to the 70-year-old guy who's 80 pounds overweight, has diabetes, hypertension, atrial fibrillation, and COPD. That guy needs to see me every 3 months at least. But that decision is made, in my opinion, in the AWV.
And I think that speaks to consistency and continuity of care.
Oh, yes.
For one of my specialists, I've not seen the provider, but I've seen 3 different NPs in the last 2 years. They don't know me. They don't even know it's in my chart. They're asking me questions, and I'm like, the doctor that's in your office did my surgery, but you don't even know that. Like, you don't know me, and that doesn't build confidence for me as the patient.
Primary care is completely different. Primary care is a completely different breed of cat. It is your job to know everything about that patient. Not know everything, but maybe be aware of everything about that patient, so that you're like, oh, you have this, you're seeing this specialist. Okay, how's that going?
One thing I hear a lot is care gap data, and high-risk patient data, and those kinds of things. So does that play a role at all?
So a care gap would be, correct me if I'm wrong, a care gap would be many, many things. So a woman who's due for a mammogram, who hasn't had her mammogram yet, that's a care gap.
Yes.
A patient who's diabetic who has not had their hemoglobin A1C checked, that's a care gap.
Yes.
A person who has congestive heart failure and is not on an ACE inhibitor, that's a care gap. A person who has coronary artery disease and is not on a statin, that's a care gap, right?
That's my understanding, yes.
Okay, so we're on the same page. So both preventive things, mammograms, colonoscopies, and treatment things, ACE inhibitors in congestive heart failure, statins in diabetics, statins in coronary artery disease. And those both fall into the category of care gaps. Now, how does high-risk patient data differ? So what would you consider, what would fall into the category of high-risk patient data? People who have a high RAF score, people who are just admitted to the hospital, people who are at high risk for falling, people who are on high-risk medications. What would you consider high-risk data?
Well, I think for us, and some things that I know that our data people are looking at is if they have multiple comorbidities. Then, so I guess it's not actually a RAF score per se, but it's factoring in.
But like, it is kind of a RAF score. It kind of fits with that. It's the same. It's looking at the same data, the same concept.
Yeah, the same concept, or like high cost of care.
Frequent hospitalizations. Like, for example, I had a patient who lived alone, elderly woman, lived alone, and she did have a lot of medical problems, and so she was a little bit worried, and I think she was afraid that she was going to die alone. I think that was her biggest fear. She had heart disease, she had congestive heart failure, she had bad lungs, and then her family would hire a caregiver for her, but that caregiver was there just on weekdays, and then on the weekends there was nobody there. And so this woman would end up in the emergency room. Yes, she was a high-risk patient, but that's not why she was in the emergency room. The real reason she was in the emergency room is because she was nervous, because she was scared, because there was nobody there. What if she had a heart attack? What if she had a stroke and there was nobody to, what if she fell down and then there was nothing to do? So high-risk patient data, I'm going to be a little bit a stickler here, and I'm going to say there's high risk and then there's high expense. That's why I'm kind of So what are we talking? Are we talking high risk or are we talking high expense? Because they're not always the same thing. This woman that I'm talking about right now was a high expense patient because she would go to the ER and inevitably the ER would find something. She's an older woman, and she would tell them, that her tummy hurts or whatever. And so they would check a urine on her, and lo and behold, there was bacteria in her urine, which is very common in older women anyway. And so they would diagnose her with a quote unquote UTI. Whether she had a UTI or not, maybe not. Why do her UTIs only happen on Saturday? Why, when there's nobody there? Why does she never get a UTI on Tuesday afternoon? When our clinic is open? You know what I mean? And so, how do we use data? So let's talk first about care gaps. I love the care gaps information. So you send me that, and I say, here's all the women who are due for mammograms. That's easy. Hand that to somebody to call these women to order their mammograms. You don't need a doctor's appointment to get a mammogram ordered. There's some things you need a doctor's appointment for. Pap smear, you need a doctor's appointment for that. Mammogram, you don't need a doctor's appointment for that. Cologuard, colonoscopy, you don't need a doctor's appointment for that. So give that to one of your MAs or one of your staff and have them call and get that taken care of. Other care gaps, A1Cs, things like that. Now, often if a person is due for an A1C, that means they're probably due for an office visit, and so they don't necessarily need an office visit for an A1C, but I want an office visit. If we're going to be talking about diabetes, I would like that to be an office visit so I can look at their meds, because there are other things, they make sure they're on statins, all that kind of stuff. So I like the care gaps information. I find that very, very helpful. Trouble is, you always try to run a lean office. You try to have as few people as possible. You try not to have extra people. And then who are you going to assign to do that? And so that you have to hire somebody. That's going to cost money to hire somebody to chase, to bird dog all of that and get that done. I'm going to say high-risk patients and high-expense patients. I'm going to divide them into two different groups. And the high-expense patients, I'm going to call those high-expense unrelated to the risk. So you have the high risk that may be high expense because of the risk. They have congestive heart failure, they have a diabetic foot, they have chest pain, whatever. So those high risk patients are also admittedly high risk. So how do you deal with those high risk patients? I think CCM is the way to go with that. Chronic care management, Medicare chronic care management. Make sure that those people have a nurse. Make sure that they can call, anytime during business hours and talk to that nurse. That saves me so much trouble, that these patients have a personal relationship with this nurse. So when they see me once every 3 months, I haven't discussed this person for 3 months, but then I look at the note and the nurses talk to them, maybe twice a month for that time. That saves me so much time. And not only does it save me time, it provides good care for the patient. They call in, they say, I'm out of my medicine. Well, have you called the pharmacy? Oh, you called the pharmacy? Yes, just like last time. And so they call the pharmacy, they get their medicine, or whatever. They have trouble with whatever. So those people, the high expense patients who have medical problems, I have to admit that the second category of people, or the third category, but the second category of high risk people, high expense people who don't necessarily have a problem, like my sweet little old lady who would just get nervous on Saturdays because there's nobody there. That's a tough one, because that's not a medical problem. I went to medical school. I am trained. I am overtrained on how to deal with medical problems. If somebody needs a statin, I know how to fix that problem. If somebody's fluid overloaded, I know how to fix that problem. If somebody's potassium's too high, too low, I know how to fix that problem. If somebody's A1C is too high, too low, I know how to fix that problem. Whether the patient goes along with it or not is a different story. But I know how to fix that problem. Somebody's lonely on a Saturday night, I don't know how to fix that problem. They didn't teach us that in medical school. There's somebody else that needs to fix that problem, and it's not me. And I don't know what the answer is. And you see a myriad of people who are homeless, people who don't have reliable food, don't have reliable nutrition. You don't need a medical degree to fix that problem. And I'm so busy working on problems that require a medical degree. I mean, you can't ask the daughter to adjust their A1C. You can't ask the daughter to ensure that this person has a statin medication. I can't even expect the daughter to know that they need a statin medication. Well, why are they on a cholesterol medication? Her cholesterol's normal, but she's diabetic. Yeah, but what does that have to do with cholesterol? Well, studies have shown that diabetics, even if they have a normal cholesterol, should be on a cholesterol medication. It helps protect their heart. I don't expect the daughter to know that, but I do expect the daughter to know how to get food, how to have them a place to sleep at night, stuff like that. And somebody who doesn't have a daughter, or somebody who has a daughter who's busy that day, that week, that month, that year, you know what I mean? That is probably, that right there is probably my biggest, I don't want to say frustration because that's a negative word, but my biggest problem that I just don't feel like I've got the skill set and the tools to fix. And I wish that somebody else would come and ride in on their white horse and fix that, because like I say, I've spent a lot of time knowing how to fix these set of problems. And that problem is outside of those set of problems. Not that I don't care about it, but I feel like you don't have to go to medical school to fix those problems. Have somebody else fix those problems who didn't go to medical school. You know, is it social workers? Is it through the medical office that gets fixed? Is there some other office that should be fixing that? Ideally, in an ideal world, it would be their family. Yeah. But not everybody has either family members who are either available. I mean, like I have patients who their kids are back in Iowa. You know, they're snowbirds and they're here and they're driving an RV around the country, and the only one that knows how to drive the RV is the husband. The wife doesn't know how to drive the RV. Then the husband has a heart attack and dies, and now the wife is stranded here in Arizona, and she has her RV parked at an RV park, and so she has a place to sleep at night, and she can go, has friends take her to the store and buy her food, but she doesn't have anybody else to help her with all this other stuff. And that she ends up in the emergency room because she has a cough and she has no way to get to my office. So she calls 911 and gets taken via ambulance to the ER for a cough that could have been treated in my office with just an acute care visit. And so that I do not have an answer to that, and I don't know what the answer is.
This is controversial. Is it the role of the health center?
And that's just it. Is that the health center's responsibility? And whether it's our responsibility or not, the fact remains that it impacts their health. And if I'm trying to prevent disease, then maybe so. Then maybe it does need to be somebody else at the health center. But I feel like for every minute that I'm doing that's a minute that I'm not doing something else that only I can do. There's a handful of things that only I can do, and I need to do the things that only I can do, because if I'm spending time doing things that anybody can do, then who's doing the things that only I can do? Nobody, because it's not like they're going to do it. And so ideally it would be at home or their daughter or their son, their spouse or something, but barring that, I guess that could be provided for at the health center. Yeah.
That's why I guess it takes a team.
Yeah, I don't have the answer to that. That's a tough one. I don't have the answer to that because I consider that not directly medical, and I wish that got taken care of behind the scenes. I put that into the category of how to pick up your meds. I prescribe the med. I send it to the pharmacy. How the patient is going to actually go and get that med, I don't care. Somebody else figure that out. Yeah. Okay, what if they can't figure it out? Well, what am I going to do? Drive them there? Am I going to put them in my car? I can't do that. And that's kind of, I put this kind of stuff, not that it's not important, because it is important, but somebody else somewhere, either in the health center, out of the health center, somebody else needs to be figuring out how to solve that problem.
Yeah, and if you do recognize that during the visit, like, the patient says, well, I don't have transportation, so I can't drive to get my medications, or I don't have the money to get my medications, then perhaps there's someone at the health center that knows of community resources, or there's resources within the health center.
And that's where the CCM nurse comes in. The CCM nurse just does all this magic behind the scenes. I don't know half the stuff she does. I probably don't know 80% of the stuff she does. All I know is it gets done, and that's what matters. And that's where the CCM nurse, person calls in. I think that's a perfect example. I don't have the money to get my meds. I'm a doctor. I can't fix that.
Yeah, but you can talk to this person,
right,
or this person can help you with that.
Right.
So
then
we're not just kind of dropping the ball.
Right. Then the CCM nurse knows how all of those kind of magical, behind the scenes, mystical things happen, and she takes care of it. All I know is I see the patient, I evaluate the patient, I determine that they need medication, I prescribe the medication, then something magical happens, and then they take the medication. And I don't care about the something magical happens, just as long as we get to the, and then they take the medication. And so is that the health center that's responsible for that? Maybe so. I mean, to say I don't care doesn't mean I don't care. Of course I care, but I don't care how it gets taken care of. I don't care who takes care of it. It just needs to be, it needs to be done, and this needs to be thought about. It just shouldn't be taking up space in my brain. I should be able to just turn this over to somebody else, and that somebody else just makes it happen. And currently, in my opinion, the best person for that is CCM. And we have another person in our clinic called a care coordinator. So we have chronic care management, and then yes, we have a care coordinator. And the care coordinator takes care of a lot of that stuff behind the scenes. And we have behavioral health and all those. And we have something called Chiricahua Cares for people who don't have the money to pay for certain things. Like if they need a ride up to see a specialist in Tucson, then we can pay for that. If they can't pay for their medications, then we can cover some things like that. And of course we have sliding fee and that type of stuff. So there are all of those things, which are all good, which are all wonderful, but don't tell me about it. Don't get me in that loop. Somebody else take care of that. I've got enough on my plate saving lives and stamping out disease that I don't have the bandwidth to handle that.
Yeah, and that's why I think the team approach is so important.
Yeah,
you know,
I agree.
And working at the top of our license or whatever that is, because that's what we were trained to do. I mean, it just makes sense, you know.
Gone are the days of one person doing it all. Like I remember when I was working at the hospital, and one of the older general surgeons, he had, you know, case cards for hysterectomy and total hip and these. And I'm like, Dr. Nally, do you do total hips? He's like, that was way back when general surgeons did everything that came through the door, and it's not that way now. It's
different approach to care for sure.
Right.
Thank you for joining us in the exam room, where we examine the vital signs of value-based care and diagnose what's shaping the future of healthcare. We hope this conversation was as insightful as your last checkup. A big thank you to our guests for sharing their expertise and prescribing actionable ideas. Stay tuned for more episodes as we probe the topics that matter most in value-based care. Until next time, take care, and thanks for listening to The Exam Room.